Uh, so that even the person who has a very specific memory disorder, good insight, is also very likely to require some psychotherapy to help them deal with the emotional issues. Their family will require some additional support and counseling in order to deal with this disability. So again, although I'll be talking specifically about techniques, in almost every case, these techniques are best applied in a holistic setting. Much of what I'll be talking about is based on the work of a large group in the American Congress of Rehabilitation Medicine. I want to recognize the other people who participated in this group, most especially Dr. Keith Cicerone, who was our leader and whose name some of you may recognize from the literature. For those of you who aren't familiar with the evidence-based approach to medical practice, I'll review it very quickly. The idea here is to rank information in the scientific literature on various medical assessment and intervention techniques according to the strength of the evidence. Now, this tradition comes from primarily studies of pharmaceuticals, so it's a little biased that way, and I'll talk a little more about that at the end of the lecture. And there are various systems for ranking the strength of the evidence. One system, most of them resemble this kind of three-tiered system where the top tier are studies that are supported by very rigorous randomized controlled studies. At the second level are less rigorous studies with some controls, either a cohort study or a study that compares the active treatment group to a historical treatment group, or a non-randomized kind of controlled design. And then the lowest level would be studies without concurrent controls, case studies, studies that demonstrate the effectiveness of it or the efficacy of a technique, but in a less than rigorous way. So each report, each scientific report is ranked and classified onto one of those levels. And then the strength of the evidence overall, as one reviews the literature in an area, is translated into some recommendations. The highest recommendation would be a practice standard, and that requires the support of rigorous scientific evidence. And a standard is really basically something that you should do. If the patient meets or is similar to patients who have been treated in the research in this area, then this is a strong recommendation that this is a technique that should be applied. If the support for the technique is less rigorous, it would be the recommendation would be at the level of a guideline. This is something that you should carefully consider doing, but the strength of the recommendation is less strong as at the level of a standard. And at the level of an option, there is some evidence there, but such that the recommendation for its use can't be strong. On the other hand, there's evidence to support the use of this technique in specific cases. It's not a bad thing to do. It's not a bad thing to try. There is some scientific evidence. Now, I'll say a little more of this about this at the end of the lecture. To some degree, at least in the English-speaking world, I think we've gone a little overboard with evidence-based medicine to the point where some people feel that the only techniques that should be applied are ones that are supported by randomized controlled trials. Now, that is not the idea of evidence-based medicine, and the originators are very clear about that in their writings, that the idea of evidence-based medicine is to communicate the strength of the evidence. But in many areas, we don't have strong evidence, so we need to do the best we can and use the evidence that we have to make our decisions. So with that setting, let me tell you about a couple reviews, and these are in print, and you have references in your handouts that you can look at in more detail if you haven't already. We have done 2 reviews so far. There's another one in press looking at a large number of studies, as you can see. It was interesting that the standards and guidelines that were developed in the initial review in 2000 really did not change substantially in our second review. And in the third review, that it will be out in a year or so, again, the standards and guidelines really did not change that much. What has changed is the strength of the evidence. So we have more evidence and better evidence for these techniques. So the things I can recommend to you, again, do have fairly good scientific support. As an overview, what you see on this slide is that compared to various types of controls, and on the whole, cognitive rehabilitation has strong support. Probably the strongest kind of control, or the most challenging kind of control, is to compare one cognitive method against another fairly active treatment. Even in those cases, we see that there's over a 60% benefit for the cognitive rehabilitation technique compared to this fairly rigorous control. If you move your eyes down the chart, that you see that compared to no treatment, or basically standard of care, cognitive rehabilitation is 100% more effective. So, overall, very strong evidence for the effectiveness of cognitive rehabilitation. Now, that does vary depending on the technique, and I'll talk about that a little more specifically at this point. We looked at a number of different domains: attention, memory, language, visual, spatial abilities, and techniques within each of these domains. Beginning with attention, the first review supported the recommendation of a practice standard, and I'll read through this with you. Strategy training for attention deficits, including training with different stimulus modalities, level of complexity, and response demand, is recommended during the post-acute phase of rehabilitation after brain injury and stroke. Post-acute meaning after the hospital, and I'll explain that a little more in a minute. A second standard is that insufficient evidence exists to distinguish the effects of specific attention training during the acute recovery and rehabilitation from spontaneous recovery. So the distinction that we're making with these two standards is that attention training appears to be effective at the point at which people's recovery of attention begins to plateau. But that introducing these techniques too early doesn't make a lot of sense because people are recovering very rapidly. It's really hard to say that these interventions make a difference in terms of that very early recovery. Good support for these techniques for Class 1, rigorous studies with almost 100 subjects. So what are we talking about, more concretely? Again, for those of you who are very interested, I would refer you to some original sources. I think Solberg and Mateer's book, now in the second edition, is a primary source for cognitive rehabilitation techniques. The kind of interventions that have been tested in this study resemble closely the ones that Solberg and Mateer recommend. And they look at attention in various different ways. One kind of attention or one kind of intervention may focus on coaching people or giving people practice in sustaining attention. So listening for things, watching things over a sustained, prolonged period of time. Other kinds of tasks involve alternating attention. So moving the attention back and forth between various stimuli. Simple tasks involve sequencing numbers and letters, symbols, alternatively, switching between various kinds of mathematical problems under time pressure. Any activity in which you have to move your attention from one thing to another, what we call multitasking these days in the lay terminology. Other tasks involve selective attention, so picking out and focusing on something in an array of distracting stimuli, and sustaining that attention, despite that distraction. Again, creativity may help here. I don't, all of the studies have used various tasks, but in a fairly creative way. One study had people do maze tasks, but with a plastic overlay with all kinds of distracting colors on it to make it a little harder. Again, trying to give the patient practice in focusing their attention to the task at hand despite these distracting stimuli. And then yet another set of tasks involves divided attention, something like alternating attention, but actually trying to do two things at once. Cooking a meal while you're listening to the news, or paying attention to your 3-year-old while you're trying to cook a meal. In everyday life, we're required to do many of these kind of things. We can replicate similar tasks like that in the laboratory or in the clinic, and there's evidence that giving people practice on those kinds of tasks may generalize into real life. Although again, I have to qualify that to say that the evidence is not always present for the generalization component, although it is in a few studies. In attention process training, part of our basic idea is to gradually increase the difficulty and the complexity of the tasks. So start easy and get hard, and to plan for generalization. So especially with people with brain injury, and I think you'll probably hear this from all of us throughout the day, what we learn in the clinic or what the patients learn in the clinic does not or will not translate into real life unless there is specific attention to helping them make that translation. That usually involves homework, often with coaching from families or friends or people who live with them outside of the clinic. In order to accomplish that homework, it's important to identify functional activities that the patients may become involved in. That replicate the kind of simulated tasks that we do in the clinic. And here's some examples of various activities that require divided attention, selective attention, alternating attention, timing a meal so that all the courses come out in order, carrying on a conversation while you're playing cards, like we said before, attending to children while you're making a meal. Throughout the day, we all have to multitask. We all have to divide our attention. We're all challenged in sustaining attention. To find tasks, again, that are pertinent to the patient, are relevant to the patient, that they can practice in real life is important to the success of this kind of intervention. One other thing that is clear as you read through these studies is that it's important to coach patients on strategies that they may use to improve their attention. One basic strategy is simply orienting to the task, kind of previewing, what they need to do. What is the task? If I'm going to make a meal, what are the steps? Do I have instructions that I can consult with? If I'm going to read an article, something that at least in the States, we were all taught to do in grade school. Don't just begin reading, preview the article, ask yourself some questions about what it might be about, go ahead and read it, but then review, take some notes, try to remember what you've read. Doing things in a more organized way can help focus attention. Other basic strategies are pacing oneself. Dr. Prigatano mentioned the importance of paying attention to fatigue. We all fatigue. People with brain injuries seem to fatigue more easily. There is no sense, absolutely no value in pushing through fatigue, but patients need to learn this, that when they become fatigued mentally, it's time to stop, and it's time to switch to something else and come back later. Along those same lines, they need to be coached, something that the psychologists in the room all know, that spaced practice is better than mass practice. So if you have to study for an exam or learn something or even just read an article for pleasure, probably better to read it in 5 or 10 minute segments as opposed to pushing through for an hour and a half. Of course, avoiding distractions, building this habit of self-reflection, thinking about what you're doing, again, orienting, focusing attention, and developing systems of social support, getting friends and families to help, and also to support the idea that pushing through is not a good idea. It's better to do things slow and steady in a spaced way. I think, again, at least in the United States, there's this strong idea that pushing through is the answer to everything, and especially in this case, it certainly is not. But sometimes families need to understand that too, not only patients. Another domain that we looked at in some detail was rehabilitation of memory. And this becomes more complicated, mainly because our terminology is confusing. And I'll try to clarify that a little bit. In fact, the practice standard, I think, is somewhat confusing because it says that and it is a standard, it is a strong recommendation, that compensatory memory strategy training is recommended for people with mild memory impairments due to TBI. But that word compensatory really includes two very different things. One is an internalized strategy in which you use memory techniques in order to remember better. And the other is an external strategy, which is using a memory notebook or some other device or external means in order to enhance your memory. Again, good support for these recommendations. Over 150 subjects in 8 rigorously controlled studies, 2 of which were specific to the use of a memory notebook. There was also the implication in these studies that this type of training, and now let me be clear, the kind of internalized strategy training is most appropriate for people with mild memory deficits who basically really want to improve their memory. And you can see the description of the kind of patients who seem to benefit from this internalized strategy training. These are people who are fairly independent. They understand they have a memory problem. They're capable of doing this independently and using these strategies independently, and they're encouraged socially to do this. Frankly, I don't understand this kind of person. I got this I got this iPhone, and it is a wonderful thing. I don't have to have a memory anymore. I could look up everything on the web or in my notebook, and actually it's a great relief. There's a book in English that I recommend to. Well, let me back up a minute. The kind of person who really wants to do this, at least again in my culture, is this highly driven business person who wants to be completely independent and wants their memory back. And they will spend a lot of time learning strategies in order to have an independent memory. If that's what they want, if that's okay. I'm willing to do that. On the other hand, I usually try to talk them out of it. And one technique I use is to give them a book called Getting Things Done, written in English. Getting Things Done that was not written for people with brain injury. It was written for high-level executives in order to help them function better. And the basic premise of the book is try to remember as little as possible, because that just clogs up your mental functioning. As neuropsychologists know this, that if you are spending a lot of mental energy trying to remember details, you really can't think conceptually. You literally miss the forest for the trees, if you know that expression. Again, to high-level, highly intelligent businessmen, this author is recommending get as much stuff out of your memory, onto disk, onto secretaries, onto your Palm Pilot or iPhone, so that you can free up your mind for thinking. And again, I think that is the first recommendation to our patients. I've also found that this book is appealing to them because it's not written for people with brain injury. It doesn't mean there's something wrong with them. In fact, we're recommending techniques that are very similar to the ones recommended to people who are functioning at a very high level. Now, I said this area was a little confusing because there's yet another kind of compensatory strategy that has more to do with procedural learning and learning to do things through rote practice. And this also is recommended, at least at the level of a guideline in some situations. These kind of techniques facilitate the acquisition of very specific knowledge. So, on the one hand, memory is not a muscle. Practicing memory techniques does not make your memory better. But rehearsing something over and over will build that specific memory. So for a person with a fairly severe memory problem, if there are a few activities that they need to learn in order to function, such as putting a TV dinner into a microwave, if they practice that enough, they can learn to do that. And that may be a very valuable skill. Or if there's a work task, that they can learn through repetition that will be of value to them, and having, some occupation, that's of high value. Dan Schachter and colleagues did a remarkable study, I think it's been almost 25 years ago now, where they taught people who were completely amnestic, had no memory at all, how to do computer programming. And they did this by repetition. They learned these simple computer entry, data entry techniques through repetition over and over. With enough repetition, they were able to do them quite reliably. And Dan said you could turn the person away from the computer and say, "What's your job?" And they had no idea. I mean, they had no declarative memory. But they could learn this procedure of entering data into the computer. So when they turned back and given the information, they could begin to enter data again. The difference, for those of you who may not be familiar with all these terms, the difference between declarative memory and procedural memory is one of learning by doing versus learning what we usually think of as knowledge. So much of what we learn in school is declarative memory. Procedures are things like learning to swim. And if you've ever tried to teach a child to learn how to swim, you really can't tell them how to do that. You have to show them. And then they have to do that. And then after a while, it becomes second nature. Same way with golf. You can't. I'm learning that the hard way. You can't be told how to do a golf swing. You just have to practice and practice. But then when you've got it, it's there even after a brain injury. There was a remarkable example on television. I remember this from many years ago, of a famous pianist who was being interviewed in his 80s on television. And it was very obvious through the interview that he had a resting tremor. And it was a very interesting interview, but through the whole thing I was thinking, oh my goodness, I hope they don't ask him to play, because this is... And of course, at the end, they did. And the remarkable thing was, he played remarkably well. And the only way I can explain that is, that activity was laid down procedurally so well that it overcame, the more peripheral problem that he had. And, we do see this with people with brain injury quite reliably. In fact, we've returned at least one person to work doing micro-programming. I'm not the dumbest person in the world, but I never could understand exactly what he did. It was so technical. It's not machine language, but it was micro coding at IBM. But it was a procedural skill. Although he had a very severe brain injury, he retained that skill. And, after we addressed some other issues, was able to return to work doing microcoding for many years until the world of microcoding changed, and then he was not able to function anymore because he wasn't able to learn the new stuff. So anyhow, long story, but making the point that for some activities that are more procedurally based, repetition is a good thing, though I think it's important to be selective. It takes a lot of time, it takes a lot of energy to help people learn or learn again these procedural activities, and so I think one has to be a little selective in choosing which of those you focus on. Keith Cicerone and I tried to make some sense of this by looking at the differences between the way these memory processes are regulated and whether they're internal or external. So in one quadrant, you have internalized memory strategies, things you do in your own head under your own direction to enhance your memory. I'll give you some examples of these. These are things that these stage mnemonists do in order to show you how great a memory they have. In the lower quadrant, you have self-directed use of memory aids. So this is something that's under people's own control, but the memory use itself is outside of them. Yes, these are a memory notebook or a BlackBerry or a Palm Pilot. In the upper right-hand corner, you have domain-specific training. This is the more kinds of procedural learning that we've talked about, of learning through a particular procedure or a particular activity through repetition. And then at the very lower quadrant on the right, you have externally directed systems of memory aids. These are things like paging systems, reminders from other people that are not under the patient's control and completely external to themselves. All of these things work. Careful assessment of the patient determines which are most appropriate to their situation. Maybe more than one. Just to give you a little better idea of what we're talking about, internalized memory strategies involve things like developing images. A peg word technique is a classic technique for remembering things. Method of loci, if you have a list remember, you may put it in around the rooms of a house that is well integrated into your memory. Using acronyms, medical school. Medical students use acronyms all the time to remember various things. I'm always reluctant to tell a joke in another culture because they don't always translate, but I'll give it a try because the imagery technique is one that we were talking about the other day, and I was telling Dr. Ben Yashay about an elderly man who I'm friends with, who was complaining to me about the way his memory is declining. Actually, even more elderly than me, if you can imagine. And he was complaining about how his memory is declining. I said, "Oh, that must be frustrating." He says, "Oh, but I've got a system. I've got a system in which I imagine something that reminds me of what I have to remember, and it works quite well." And he said, like, for instance, my wife and I went out to dinner last night to this very nice restaurant, and I can't think of the name right now, but I'm thinking about a flower, and it's, one of those flowers with a long stem, and it's red, and people give them at Valentine's Day. And I said, "Oh, you mean a rose?" He says, "Yeah, that's it. Rose? What was the name of that restaurant we went to last night?" Good, it worked. Actually, that's not entirely funny either. I saw one study in which they showed that elderly couples, men and women, when tested on autobiographical memory tasks, things that had happened in their lives, independently of each other, had relatively poor memory, but together did excellently. So another good memory aid is to get married and stick with her or him. Examples of external memory aids, shifting gears here, again, your creativity, I think, is important here, but these are commonly used examples. One thing we've found is that the younger generation, basically meaning people under 30, do quite well with electronic organizers. Older people do not. Again, because the younger group has had experience with these kind of electronic organizers before they were hurt, so they don't have to relearn the procedures. Whereas for the elderly people, this is a new thing, so they are often more comfortable with paper and pencil and some kind of a notebook. The idea of systematically developing that notebook or that memory aid is very important. Again, underlying a lot of this is organization. You'll remember that even in attention, it's important to get organized and focused. Certainly in developing a memory aid, it's important to organize the notebook or the external aid in a way that's relevant to the patient. And in our patient group, we've had everything from very elaborate notebooks that seem to appeal to people with a lot of, who may have had experience with date books beforehand and have a lot of activities to keep track of, to, very thin little items. I remember we had one guy who worked on heating ducts who needed to keep track of some information, but not for a long time. So he just had a little bitty notebook, that he would open up. He'd write himself some notes. He could stick it in his pocket, which he really liked. He didn't want to have to carry something around. And then, when he didn't need that information anymore, he could tear it off and throw it away. That doesn't work for most people, but it worked quite well for him. Again, a point that Dr. Prigitano made, adapting these techniques so that they're relevant and pertinent to the person is extremely, extremely important. Shifting again to this idea of domain-specific procedural learning, the idea of practice to develop specific skills. Again, don't be fooled. It doesn't make your memory better, but you can learn the skill. And there's various techniques such as priming and vanishing cues that can assist in that. As I mentioned before, important to be selective in which tasks are targeted for this kind of intensive intervention. And then finally, externally directed cues, paging systems, reminders. Dr. Wilson did a randomized control trial showing that a paging system in which people with very severe memory problems were simply called up on a regular basis to remind them what they were supposed to be doing at that hour of a day. They found that that kind of a system was very, very effective. Shifting again here to language and linguistic remediation. Very strong evidence that basically aphasia therapy has an effect. Aphasia therapy is probably more common or more relevant after stroke than after brain injury, simply because of the nature of the lesions. That the language area may be affected in brain injury, but is very commonly affected in left hemisphere stroke. And again, strong support that these kind of interventions help, specifically for language, at a little lesser degree of strength of evidence, also with other language functions such as reading and developing language. One thing that came through in this literature is that treatment intensity is an important issue and a key factor in the outcome. And that's intensity at both ends. So in other words, you can push too hard again, you can do too much, but you can also do too little. So being able to find the right intensity for this patient at this time is an important thing to keep in mind in order for the treatment to be effective. And although, the evidence was strongest in this area of language, I think that's a lesson to be learned in any kind of cognitive rehabilitation, that, more is not always better. There is, in fact, a right amount of practice and intervention for this to be most effective. As you can see, many studies, many strong studies supporting these interventions. Also, some evidence, and there's been some additional controlled trials since these last reviews, recommending that not only can specific language functions be retained, but our ability to communicate can be retrained. And by the ability to communicate, I'm talking about all those non-language activities in which we engage. The kind of things that allow me to communicate with a store clerk who doesn't speak my language, what I want. I can look excited, I can point, I can nod, and most of all, I can understand that I have to pause and stop and wait for a reaction. All those kind of things that in a sense are second nature in our communication. Knowing when to speak, when not to speak, when to listen, when it's somebody else's turn, when it's your turn. After brain injury, often those kind of things are lost. The good news is there's increasing evidence that those kind of communication activities can also be retrained. At the level of an option, something that's a possibility, computer-based interventions appear to be helpful, although as you'll hear from me again later, that we don't recommend using a computer without very active therapist involvement. In terms of increasing intensity, you can, of course, increase frequency, but another way to increase intensity, if that's desirable, is to engage other partners. So engage a spouse, a friend, a brother, a sister in coaching some of these language activities. And again, computerized treatment can be an adjunct and another way to increase intensity without actually increasing number of hours in the clinic. We talked some about these functional communication skills, the pragmatics of communication, taking turns, getting the right sequence. The example that Dr. Prigitano gave, of the young man who would kind of start his story in the middle, progress to the beginning, and never get to the end. That is really not uncommon after brain injury, but it's something, again, that can be retrained, with practice and feedback, and particularly in a group. Dr. Prigutano also talked about the value of the group, and I think we'll talk more this afternoon. And the use of feedback mechanisms like videotape can be helpful in this kind of training. Moving on, another area was visual spatial remediation. Again, probably more relevant after stroke than brain injury because of the nature of the lesion. These interventions have been primarily focused on visual neglect, so not being able to attend to the contralateral side of space, more common in right hemisphere lesions than in left, because some sense from the people who study this that the right hemisphere may be more involved in attention than the left hemisphere. So this kind of inattention, is more common on the left side, more common after right hemisphere stroke. May also have to do with the particular activities of the right parietal lobe, which are more involved in spatial perceptions. Again, strong evidence at the level of a practice standard to support a standard that visual spatial rehabilitation for neglect can be effective. And a strong sense, although it's not perfectly clear in literature, but a strong sense that giving people practice in scanning, visual scanning, is a critical element of this kind of retraining for neglect. As you can see, a large number of subjects in 8 studies, over 300 supporting this type of intervention. This is kind of not a very, very well done example, but at least it will give you an idea of what we're talking about in terms of scanning training. The task might be something like this, where you're asked to look at that red cross in the middle of the screen, and then what happens is letters begin to appear in the periphery. And so while you keep your attention on the cross, you are also asked to pay attention to the letters and recite the letters as they appear. So people get practice in scanning their environment and becoming more attentive to the left side of space. Again, on the PowerPoint, it's probably not the best example, but at least it gives you a feeling for what this task might be. This kind of task is not well delivered on a little computer screen. And again, you can imagine why, because you really want to challenge the entire visual field, and the computer screen is too small. However, one very clever investigator used a projector system for his computer, so now he has a very big screen that does in fact challenge the entire visual field, and also is very much handier than trying to construct the large plywood device that Dr. Diller and Gordon and others at NYU did many years ago. There's much less evidence about training more complex visual spatial activities. Route finding, getting things in the right order on a table, for instance, setting a table place, orienting things for cooking. I think this is an area where we need much more research. There's some evidence to suggest that those, practicing those more complex visual spatial tasks may be of value, but the evidence is not as strong as in basic scanning activities. It's also the recommendation, at least at the level of an option, that one carefully consider the kind of patients who receive this kind of training. As I mentioned, that neglect is much more common after right hemisphere stroke. So I think in cases of left hemisphere stroke or brain injury, whether this kind of training is relevant or not has to be carefully considered. In fact, there's some people who really don't believe that neglect can occur after left hemisphere stroke. I feel like I've seen a few cases, so I don't know that I agree with that entirely, but at least there's controversy. And certainly I think most would agree that's infrequent after left hemisphere stroke. There has been some increasing evidence that the use of limb activation in conjunction with those kind of scanning activities I demonstrate may improve the effectiveness of these interventions. So by limb activation means, to the degree that the person can, when they see the stimulus on the left side of space that they're neglecting, that they also attempt to point to it. They attempt to make a muscular movement, motoric movement. This reminds me of some of the comments that Dr. Stein made yesterday about involving the whole brain. And I think, again, those of us in holistic rehabilitation would certainly agree, that the more of the person, the more activities that can be reasonably involved in a training activity, the better. Now there's a group in Germany, and I just mentioned this very briefly, there's a group in Germany that has also had at least one randomized control trial demonstrating that visual fields can be expanded through a very kind of specific computer training that they have done. Now, this is different than neglect. They're not talking about inattention to one side of space. They're talking about an actual cut in the visual field. There's no vision on that side because of damage to the occipital cortex. Now, most of us would believe that that is not possible. As the visual cortex has been damaged, you really cannot restore the visual field. Of course, I think none of us also want to be among those people who 100 years from now are proved to be wrong. So, we have to admit that they did supply at least one rigorously controlled trial saying that with this technique, those fields may be expanded. However, I think we still have a question mark by this technique and would like to see it replicated in other laboratories before we endorse it entirely. Apraxia, the inability to make complex movements, is another area in which there's relatively strong evidence that training can improve these kind of activities. Again, people make this distinction, which probably has some validity, that the right hemisphere is more of the perceptual, more of the attentional hemisphere. The left hemisphere is more of the motoric, acting hemisphere, the sequential hemisphere. So apraxia seems to be more common after left hemisphere stroke. But training in those kind of activities, again, can be effective. Now, as we move into areas of more complex cognition, like executive functioning, and that term executive functioning, I think, captures a wide range of things. I mean, everything from relatively simple regulation of complex attention to high-level reasoning, some of the most complicated activities that human beings do, planning, organization, all of those things kind of fall in this under this broad rubric of executive dysfunction. And as those of you who work with people with brain injury know, very commonly impaired after traumatic brain injury. The evidence is less strong for remediation in this area, but at the level of a guideline, we could recommend that formal problem-solving strategies and their application in everyday situations and functional activities can be recommended. This is an area of very active research in the States. Again, Wayne Gordon and his group at Mount Sinai, on the other side of New York, right, are very actively investigating this area. I know, Dr. Diller has done some of this work in the past. Outside of brain injury, as well as inside of brain injury, there's quite a bit of interest in this set of computer programs marketed by Posit Science in terms of retraining executive function, both in Alzheimer's disease as well as in brain injury. So I think in this area, to some extent, the jury's still out. We're still waiting for results, but there is a number of active research studies in this area, which I hope will give us more information in a relatively few years. At this point, some support for these activities, some small studies with some degree of control. Again, just to give you an idea of what we're talking about, a kind of activity that might be used to retrain problem solving is something like this, where the folks with brain injury are given a a chart like this. In our program, we just run a lot of these off and use them whenever they have a problem to consider, and get them in the habit of doing this in a systematic way. Actually, this was something my dad taught me how to do when I was about 12 and going crazy about something. It's not out of normal experience. He said, well, write it down, and then what are the solutions, and which do you like the best? Okay, try that. If that doesn't work, then try the second one. Maybe get some feedback from other people. Sometimes our folks with brain injury come up with some maybe not so good ideas, about how they can solve a problem. So to get some feedback from the group about whether that's a good idea, well, maybe not. Maybe we'll just cross that one off the list and try another one. So, one of our patients had a very simple problem. He needed some money to buy a CD that he wanted of a singer that he was very, very fond of. So, he's trying to figure out how to get this money. And some of the solutions, he and the group came up with were to borrow some money. He thought if he did a little work for his father, he might be able to make some money. He might borrow some money from his mother. And then, with the help of the group, he ranked these solutions, and they all kind of decided, and he did too, that maybe working for it would be the best thing, because then he didn't have to pay it back, and then it was really his. And so he did that, and his father cooperated and gave him a little job, and he got the money, and he bought the CD. So afterwards, he ranked that as a high degree of success. If they hadn't worked out, he might have tried another solution or developed a few more. Another approach to working on higher level skills is goal management training. And this is a chart that I took right out of the article by Levine and colleagues in GINS. And as you can see, it's simply coaching people to move through some relatively straightforward steps, not unlike the problem-solving format, to define, what the goal is, what they want to accomplish, list the steps that are going to be required to accomplish that goal, make sure they know how to complete the steps, or develop a plan for developing the skills they need to complete the steps, and then go ahead and do it. Take a shot at getting the goal. Of course, there's always that last phase of checking back and making sure that it's working, and if not, starting again and revising the plan. In the same area, the idea of developing self-regulation strategies has some level of endorsement. And we've talked again about some of these things already. I think with or without scientific evidence, it just makes sense to coach people to organize themselves, to develop this internal self-talk, often prompted by external aids, in order to keep themselves on track and be able to progress, towards the activity that they're involved in. Now, I mentioned briefly computer-based recommendations. For a while, these were very popular in the States. I think probably in some cases not well used. I know of at least a few centers where it was routine to sit 6 patients down at 6 computers with video games and call that cognitive retraining. That is not cognitive retraining by any stretch of the imagination. So the group does not recommend the use of computers without very active therapist involvement. On the other hand, with a therapist's involvement, a computer can be a handy aid. I mean, it can offer a number of different stimuli, and very, very quickly and very easily compared to paper and pencil tasks. And some of the newer computer programs, like the ones from Posit Science, may be of high value. So with active therapist involvement and monitoring, computers can be an important aid, but certainly not something that you can just turn a patient loose on and expect that that's going to have an effect. So now we come to, the very complicated kinds of interventions, the comprehensive holistic approach about which you'll be hearing more throughout the rest of this day. I'll make the point a little more forcefully at the end of my lecture that these kind of techniques really do not lend themselves very well to traditional randomized controlled trial analysis. They're just too complicated. It's impossible to blind either the providers or the receivers of these services, and blinding is an essential part of the randomized control trial. So I think we need to look at other techniques to evaluate these. Nonetheless, there are a number of reports in the literature, less rigorously controlled for practical reasons, that suggest that comprehensive holistic rehabilitation is effective. Oh, this is an old picture. Of course, Dr. Ben-Yeshai has not aged at all, but the rest of us have gotten a little older. This was a conference that Lance Trexler, the fellow in the front in the middle, convened a number of years ago for a group to talk about what is the essential elements of holistic rehabilitation. And he brought in Dr. Ben-Yeshai, Annalise Christensen, the woman on your far right there. Dr. Prigatano was not able to make it, but sent his second in command, Pam Klonoff, the woman on your left. That's me behind Pam. I still have that suit coat, but I don't fit in it anymore. So Lenny Dillard, Dr. Dillard, in the middle, in the far back